All right, goal of stretching is to improve flexibility and range of motion by elongating adaptively shortened and hypomobile structures. Trying to make the muscles and the soft tissues around the joints move a little bit better, move easier, move with less resistance. Okay, a couple of foundational points. Number one, although I think a lot of times we think about these interchangeably, the terms stretching and range of motion are not interchangeable. Range of motion exercise, if we're just talking about how much range of motion does somebody have, that stays within the available movements. The goal of that isn't to increase movement. They stay within the limits of available tissue length. The goal of range of motion is just to maintain mobility. If we do a range of motion, whether it's passive or active assist, the goal isn't necessarily to increase movement, it's just to keep what we have. Whereas the goal of stretching done correctly is to take the soft tissues beyond their available limit and increase range of motion. So please don't get into the habit of using those terms interchangeably. Range of motion is within the available range, and stretching is intended to increase the range of motion. These bottom two bullets on the left, I think we beat up pretty well yesterday. So number one, the stretch position of a muscle is the position of passive insufficiency. And this is always true. It's always going to be true. The position of passive insufficiency is going to stretch the muscle. For two joint muscles, that's really straightforward. To stretch the gastrocnemius, do the opposite, right? Extend the knee, dorsiflex the ankle. But the last bullet, in order to stretch a one joint muscle, moving to the soleus, remember to put that two joint gastrocnemius on slack over the joint not crossed by the one joint muscle. And so we tried to say this a lot of different ways in lab yesterday. This is the language your book uses, but essentially the soleus, plantar flexes, we stretch it through dorsiflexion, but we want to make sure we're not concurrently stretching the gastroc, so we take the gastroc out of the equation by flexing the knee. We put the gastroc on slack over the knee, which allows us to focus our stretching skills. And conceptually, this was what we covered with like stretching FDS FDP versus FCR FCU. It was what we covered stretching the long head of the triceps versus the lateral head of the triceps. Conceptually, all of these examples are just an application of those two bullet points. Why does stretching work? We don't really know. And that's a summary of this right here. It's just said at a little bit of an elevated use of language. The exact physiological mechanisms are still unclear. We're not sure why it works. There are probably biomechanical changes. We're going to talk about that later with the stretch-strain curve. Probably some biomechanical changes, as well as, probably more importantly, neural changes. We're inhibiting the nervous system, reducing inhibition to movement in the non-contractile and muscle tendon or contractile unit, and in the surrounding fascia, and in some of the structures around the joint, and just an improved overall tolerance to stretching. So why do we increase range of motion? We're not sure, probably for a lot of reasons. But it's not this perfect biomechanical relationship. Kind of like last week we talked about with joint mobilization, it's not just concave convex rule working biomechanically. There are other factors at play. So does it help? Probably in some cases, but we're not fully sure why. However, what we do know is people will pay a lot of money for stretching services. I think the company's called Stretch Factory, and they charge a lot of money, and people go and they lay down and they just get stretched for an hour. And if you want to know more about it, incidentally, Mackenzie, second year, works at one of these organizations, and people really like to be stretched. And I'm not saying we should deliver care for no other reason other than what people like, but what we'll see in our pain course, what we've already seen a little bit, is that the placebo effect is very real. and that the benefits of a positive alliance, which we're going to hear about today, therapeutic alliance between patient and clinician, are very real. And so perhaps all other things being equal, you stretching your patient for just a few moments might help optimize your therapeutic alliance, might help optimize whatever placebo benefits exist. And so people really like to be stretched. If they're in the clinic and you can spend just a minute with your hands on them stretching, that may benefit your care in more ways than just this biomechanical model. And lastly, if we're talking about billing, we should have a range of motion or muscle length test, that's MLT, muscle length test goal, to justify a stretching treatment. And then like everything else, we should document baseline, our progress, and how the patient is at discharge. And we document our gains or our improvements in stretching with what tool? How do we document improvements in stretching? With a GONI. Right? The GONI tells you that you treat. It's hypomobile. The end field told us how we treat. So we had a hypomobile number on the GONI with an abnormal firm muscular end field. We stretched, and then we reassessed with the GONI. If the number got better, we had a meaningful impact. But make sure you're documenting progress. This is just that gastroc soleus thing we covered yesterday. I already read this in lab, but conceptually, both stretches dorsiflex the ankle. To stretch the gastroc, we make it passively insufficient by extending the knee. To stretch the soleus, we avoid gastroc passive insufficiency by putting it on slack. For 2 days, we've talked about this concept. Is this good now? You feel confident with that? Okay. Before getting into indications and contraindications, I want to differentiate what the evidence supports and what the evidence doesn't support as far as benefits or outcomes of stretching. So number one, done over time, chronic stretching, we do see improvements in flexibility and increases in range of motion. Right, somebody who participates in a consistent, regular stretching program will probably have, all other things being equal, better flexibility and mobility than somebody who does not. Poor flexibility, so not normal as compared to hyper, but poor flexibility as compared to normal. Poor flexibility is associated with a greater risk of lower extremity injuries. If you have poor hip rotation, you're going to be subject to a greater risk of knee injury. Poor dorsiflexion, you're going to be at risk of greater risk of knee injury. So normalizing and not being on the bad end of the spectrum is helpful. Incidentally, in order to make those long-term gains, chronic stretching or stretching done over a long period of time is more critical. Just like today, for the first time in ever, I'm going to stretch. That one acute bout doesn't appear to reduce post-injury risk, post-stretching injury risk. So acute stretching done once, probably not that helpful, which isn't inconsistent with everything else we've talked about, right? If you decide you're going to do aerobic exercise one time, you're probably not going to get a meaningful outcome. If you're going to strength train one day, probably not going to have meaningful adaptations. The same is true of stretching. It needs to be done over time. And the obvious example is it's true of oral hygiene as well. We don't go to the dentist once a year and say, okay, that's going to be enough to maintain my oral hygiene. That chronic nature of it, the consistent pattern, is what's necessary to appreciate any meaningful improvements.
Does acute stretching have any acute benefits? Like if you were to work out for the first time in a year and then you decided, is it better to stretch before that workout than not stretch before the workout?
Yes, but how you stretch before the workout is important. And actually, that was a beautiful segue, thank you. We're going to touch it now, and we'll cover it in a little bit more detail later. Acute dynamic stretching. So dynamic stretching is more like active mobility. It's actively moving your body through a full range of motion. Acute dynamic stretching Not chronic stretching, not let me touch my toes for 90 seconds. That's static stretching. But rather dynamic, active warm-up, mobility drills. Does enhance muscle performance, and we've got a list of reasons why coming a little bit later. So if you, to the point from a moment ago, are gonna be active for the first time in a while, it would be better to do some type of active warm-up, active mobility work prior to being active. Not necessarily, let me touch my toes for 90 seconds. More on that to come. So all this is the evidence-based benefits. Active stretching done over a long period of time, weeks or months, is probably helpful for restoring mobility and reducing injury risk. What's it not good for? Well, there's a popular idea that it reduces soreness, muscle soreness, like post-exercise soreness. The evidence doesn't really support that. It doesn't appear to reduce delayed onset muscle soreness. There's a meta-analysis from about 10 years ago, hyperlinked if you're interested in learning more about that. Like this idea that I'm sore the day after working out, I should just stretch and it'll go away. Probably not. My follow-up to the question. Acute static stretching. So static stretching is just hold for a prolonged period of time. Acute static stretching either has no effect, doesn't help, or may reduce or decrease muscle performance. And so here's how we measure that. They'll ask a group of people to jump as high as they can and they measure their vertical leap. And then they have them do a prolonged static stretch, and they have them do that same test. And vertical jumping is an expression of power, right? It's how much force can reproduce rapidly. And what we see is following prolonged static stretching, that there's this reduction in power output, a reduction in how high we jump. So acute static stretching either doesn't help or it reduces muscle performance. So again, like how we stretch dynamically, probably helpful. Prolonged statically, probably not super helpful. I'm coming to you in a minute. Immediately following the stretching session. Now, like this became, I think, mainstream a few years ago. And then all of a sudden there was this move against static stretching at all. It's like, oh, you shouldn't stretch because it's gonna make you really, really weak. Stretching's bad. That's probably getting carried away. So all of these studies on vertical leap was when the stretches were held over 90 seconds. And I think most of us probably don't hold static stretches for 90 seconds, but to be fair to the evidence, like that's the duration that you would have to hold the static stretch to truly see a reduction in force output. Now, here's why we care. Because most of us aren't training for maximum vertical jump at this point in our lives, right? Here's why we care. The biggest factor in falls prevention is not core strength, but what? Power, yeah. So, I want to make sure that my intervention, especially when I'm training an older adult at risk of falls, I want to be sure that my intervention doesn't do anything to reduce power. I certainly don't want to send an older adult with a history of falls out into the community right after treatment with an immediate reduction in power. So prolonged static stretching in older adults, at least right at the end of therapy when you can't supervise them, might not be the best intervention because we would have knowingly reduced power. So that's why we care. And again, it's those prolonged static stretches for 90 seconds, maybe more. Hannah was first. No? Got it? Okay, go ahead.
Do you think that has more to do with the neurological side of muscle fibers or like the tissues themselves? With like power versus going solely motion and stuff?
Because you prefaced it with, do you think? I'm gonna share what I think, but I don't know this to be true, I'm speculating. I think it's the nervous system. I think like a whole lot of other things, like a lot of our initial strength gains, like a lot of our flexibility gains, a lot of it is the nervous system. Muscles are really, really dumb. So much of what we do is just training or detraining our nervous system. So much of persistent pain experience is a hyperstimulated nervous system. I think what we're going to see moving forward is so much more emphasis on the nervous system and less on the dumb muscles because all they do is shorten and elongate, right? But, yeah, go ahead.
I was just gonna say this relates to what we did yesterday about stretching because the muscle tired,
So the tired analogy that Mr. D gave, I think, is a good explanation to your patient. I think tired probably can be interpreted differently. And so when we talk about stretching and stimulation of Golgi tendon organs, we'll try to use the term inhibition, which just means the nervous system is calming the muscle, turning it off, which your patient may understand as it's tired. But I'm not going to use that term in here as much. But again, like if you're talking to your patient, I think it lands. I kind of covered a few of these in passing. Dynamic flexibility is synonymous with active mobility or active range of motion. It requires, as a premise, dynamic or active movement. The muscle's ability to contract through the full range of motion. So again, done actively. Passive flexibility. This is like the analogy I gave yesterday. Your patient's a limp noodle. The limb is going to be passively taken through the full available range of motion. Passive flexibility is a prerequisite for dynamic mobility, right? If you don't have enough passive movement, you're not going to have any more active movement. But it doesn't ensure you're going to have good dynamic movement, because if you have poor muscle strength, recognize your dynamic flexibility, your active mobility is going to be impaired. So dynamic flexibility requires, number one, passive flexibility, but also adequate muscle strength and coordination. Dynamic flexibility requires, number one, passive flexibility, and number two, strength and coordination. I'm going to pause on that and just give 3 different examples. And the first one's from your quiz the other day. Patient presents, and we'll do a joint that we expect 150 degrees of range of motion. Patient presents 0 to 120 degrees with abnormal firm capsular end feel. What's your treatment? Treat the capsule. We're going to mobilize, right? Distract. Anterior, posterior, slide, glide, whatever. If the capsule limits movement, treat the capsule. Okay, different patient. Same joint though. We expect 150 degrees. Patient has 0 to 120 degrees with abnormal firm muscular end feel. How do we treat? Stretch the muscles. Third patient. We expect 0 to 150. Passively, they have 0 to 150. The joint capsule's not impaired. The muscle's not impaired. Actively, they have 0 to 100. What's the problem? Strength. What's our treatment? Strengthen the muscle. Yeah. If passive range is normal, but active range is limited, that tells you there's a limited either willingness to move or impaired strength, right? They're unable. Yeah.
You said dynamic flexibility. You said it both passive flexibility and strength?
Yeah. I said strength and coordination. Somebody with a neurological insult might have adequate strength but not coordination for the movement. I won't use the term contracture very often, but it's in your text and I just wanted to connect it to the topic. So the contracture, you've used this term with Dr. Brigley, right? Maybe. Okay. Adaptive shortening of the muscle tendon unit and other soft tissue surrounding a joint. This is a significant and semi-permanent reduction in range of motion. This is not, I have 175 and I'm a little restricted at the end. This is profound limitation. Like a true contracture of the elbow might look like this. A lot of times, these are from a combination of prolonged immobilization and or brain injury. It's often defined as a near total loss of motion. Like the very, very worst contracture I saw was the result of a brain injury, and the individual had bilateral upper and lower extremity contractures. I mean, it was just in a ball. So contractures not generally going to be addressed or won't generally benefit from just, let me stretch you 3 times for 30 seconds. Right? These individuals either need serial casting or something else, and at the point of this significant of a contracture, you're just trying to minimize other negative impacts. Like you want to get the elbow straight enough so that you don't have skin maceration in the elbow crease. Their problems are much more significant than Gen Pop outpatient ortho. Overstretching, not good, just as it would sound. Would be lengthening the muscle and other soft tissues beyond normal length, which may result in hypermobility. So for some people, think Cirque du Soleil, if strength is normal, they're stable, fine. Their activity demands it. But for a lot of individuals, this may be detrimental if it creates instability, right? Hypermobile, stable, hypermobile, unstable. Remember that we need static and dynamic restraints to control the joint. So overstretching, not necessarily desirable, particularly in the spine, right? Because we know that excessive spinal mobility, excessive spinal range of motion is not protective. In fact, it's a risk factor for back pain. Page 90, box 4.1 and 4.2 are probably worth just highlighting right now. And I think I've said most of this. Indications to stretch. Reduced range of motion due to something that can improve from stretching. Especially if that reduction in range of motion may lead to preventable structural deformities. Muscle weakness on one side of a joint, which has led to the shortening of opposing tissues. An example of this, I think a lot of us have seen this person who's got really significant rounding of the shoulders and scapular protraction and internal rotation. Over time, we'll see that weakness, particularly of the external rotator group, allows the shoulders to internally rotate and just stay in that position. And if you watch this person walk from behind, you can see the palms of their hands. What we eventually see is a reduction in length or extensibility of the internal rotators. So significant weakness at certain joints may lead to a reduction in range of motion. They do it for general fitness and may be used prior to or after vigorous exercise. Again, if used prior, dynamic tends to be more appropriate than static stretching. Contraindications, like in a sentence, don't stretch if we're not going to improve the limited range of motion. Well, if bony block is limiting motion, we're not going to improve it by stretching. A recent fracture, right? An incompletely healed fracture. We're potentially going to disrupt healing. Acute inflammation is contraindication for virtually everything we do. It's a contraindication for stretching. It's an absolute contraindication for strengthening. It was a relative contraindication for joint mobilization. Again, we can probably do some grade 1s or 2s, but nothing aggressive that would actually stretch the capsule. Let's get this under control before we do anything else. I want to jump down because like a lot of these are self-evident, right? If there's trauma, if there's hypermobility, don't stretch. I want to just speak about these last 2 bullet points briefly, and then I'm going to kick that can down the road until neuro. So it says short and soft tissues are necessary for stability in lieu of neuromuscular control, or those short and soft tissues enable specific functional tasks. About a year from now, you'll be covering spinal cord injuries. And depending on the level of spinal cord injury, individuals will have specific predictable, semi-predictable functional abilities. And what you'll see is that in the lower cervical spine, the individual has a lesion around the C6-7 area. They'll have active wrist extension. This will be intact. They won't have good finger function. This may be entirely impaired. And so these individuals develop a functional grasp by using tenodesis. As they extend their wrist, which they have control over, they're able to functionally grasp something. If they hold their wrist in extension, because of that natural tenodesis and the flexion of the fingers, there is a little bit of a grasp. Can't pick it up like this. I can pick it up like that. So for that patient, very, very specific, for that patient, stretching of the FDS and FDP would be harmful to their ability to have a functional grasp. And in fact, we'd want that to tighten up a little bit, because the tighter FDS and FDP are, the better that functional grasp will be. Really, really specific. Another example, and I won't get into the weeds on it as much, but hamstring length. If it tightens a little bit over time, it may allow individuals, again, who've sustained a spinal cord injury, to have some degree of sitting balance, just because of the tightness of the hamstring. So in specific populations that you'll cover, sometimes there's a functional benefit to letting things tighten up. I know we talked about tenodesis first semester in a very orthopedic realm. Like when we measured the wrist flexion, we allow the fingers to extend. When we measure wrist extension, we allow the fingers to flex. But the eventual application of tenodesis is really for your patients who have sustained a spinal cord injury, a lower cervical spinal cord injury. Won't be covered in this course anymore. Just wanted to put it on your radar that this will connect to future learning. Page 111 and 112, 112, 113, don't force a joint passively beyond its normal expected range of motion. Be extra cautious if the patient has osteoporosis or if the patient has another similar disease, prolonged bed rest, their advanced age, steroid use, anything that could impair quality and quality. And we're going to talk about that extensively. Protect newly united fractures. Remember from last week, those long lever arms that we use in stretching may be more dangerous than just joint mobilization. So sometimes your first technique might just be better to do a joint mobilization before we do any joint stretching, muscle stretching. I will say this 10 times today. Avoid vigorous stretching of muscles and connective tissues that have been immobilized. Okay. I don't want you to write down any of the specific percentages. I want to make the take-home message of this what you remember. Page 95. Right column, in yellow it says effects of immobilization. And I just want to frame this really quickly. Study that was done immobilized monkey knees. Immobilized the knee. There was no injury. They just took the knee and immobilized it. That's really important. Just immobilization. So what we're talking about here is not the effect of an orthopedic injury. It's not going to be the effect of surgery. We're just talking about a healthy knee that was put in an immobilizer, okay? So the knee was immobilized for 8 weeks. Took all the knees, immobilized them for 2 months, which isn't really that long, especially as compared to how long we'll immobilize a lower extremity fracture or a significant tear. 8 weeks of immobilization is the premise. There was no injury. Okay, so reading 1, 2, 3, 4, 5, 6, 7, like 8 lines down. After 8 weeks of immobilization, the anterior cruciate ligament, ACL, in monkeys failed at 61% of maximum load. In other words, after immobilization, no injury, no surgery, just immobilization, after 8 weeks, the ACL failed just at over half its normal strength. The effects of immobilization on collagen quality are profound. 8 weeks of immobilization weakens tissue strength by half. After 5 months of reconditioning, okay, monkey went to therapy for 5 months. That should be enough. It failed at 79%, right? We're only back 4/5 of the way. After 12 months of reconditioning, it failed at 91%. What's the point? Why spend so many minutes on immobilized monkey knees? I mean, it's fine, right? We can talk about it. Why? What's the take-home message?
That it's really effective.
That it's really effective at
Deconditioning.
Yeah, like the effects of immobilization are profound at how much weaker your collagen, which is the building block of ligaments, skin, muscles, how much weaker collagen will become. No injury, no surgery, a healthy knee, put it in an immobilizer for 2 months, and when you take it off, it's going to be half strength. Yes, ma'am.
What's an example of immobilization? Like, what is something that you do to immobilize?
Oh, this is great because I was about to tell a story.
Okay.
So, mentioned last week that I catastrophized my son's elbow fracture because he had some ulnar nerve numbness, and I'm like, oh my gosh, his nerve is permanently damaged and he's never going to heal and he's going to have this claw hand deformity when he's old. Totally catastrophized. So he was in a cast for, it wasn't long, it was like 21 days. Because kids' magic power is that they heal super fast, right? And as we're driving home from the doctor, when it came off, I was like, Dad, can I do pull-ups when I get home? No, absolutely not. Today when you go home, you're going to sit in the bath and you're going to gently move your arm because I know that your collagen quality is garbage right now. I left that last part out. Garbage. So, to your question, like just an elbow fracture, immobilized in a long arm cast, which goes from here up to here, because you don't want the radial ulnar joint moving if it's radius. That would be one example of an upper extremity immobilization. Mentioned yesterday in lab that this hypothetical injury Mr. D had. He was in a sling for 8 weeks, immobilization to the shoulder.
So essentially, like you can use something like a sling or cast, something like that. So it's like you use it for healing for better, whatever, but then in result, it causes.
Right. Immobilization is necessary. If you have a fracture, we can't just like magically fix it. Sometimes surgery is, helpful, but you still need to immobilize the region to allow the bone to heal together. If you have a significant sprain that's had some tearing, well, you need those tissues to heal back together. And so immobilization is an absolutely necessary part of that process. Like our bodies immobilize things. If you've ever had a serious ankle sprain, what happens? It swells up, which limits movement. Immobilization is critical for healing. Right? We need those tissues to scar down and heal together. So I'm not trying to even suggest that immobilization is not a critical part of the medical model. But the downstream effects are potentially catastrophic. Right? We should not have our patient who comes out of a long arm cast, especially if they're not 8 years old and like heal overnight, they should not go home and do a set of pull-ups. They should not go home and hang from a pull-up bar. They should go home and actively, gently move their arm. We'll talk about how to strengthen collagen in a minute. Yeah, go ahead.
Okay, so essentially, like long-term immobilization, would that technically be like a contracture?
So when you say long-term immobilization,
I just mean like, I don't know, like in my brain, I like kind of connect it to like inflammation and what we're learning. Not literally the same thing, but conceptually, like it's necessary for healing. But
I agree with that.
long-term immobilization is not good. And like chronic inflammation is not.
Totally agreed. Chronic inflammation, not desirable.
Not.
Long-term immobilization, if it was medically indicated, it may be necessary, but the quality of your tissues will suffer.
Heals one tissue at the expense of another tissue.
Right, exactly. That's what I'm saying. But long term would, so like if you put it on like a scale, like immobilization is over here, fractures is like over here. And so like the more you have something immobilized and you don't fix it, that could turn into a fracture.
Yeah, totally agree. So you've just got to weigh like how significant is, and we immobilize hypermobilities and instabilities, right? We don't immobilize something that's strong and stable. We immobilize a fracture. Because if you break your femur and it's moving in the middle of the femur, that's hypermobile where it shouldn't be. We immobilize things that are moving too far. The treatment for excessive movement is stabilization. And while it's helping, the injured tissue, it certainly is affecting all other tissues. Yeah. Did we sort of answer your question?
Yeah, it wasn't
Okay.
necessarily a question, it was more
Yeah.
just like,
Conceptual. So immobilization, even in the absence of injury, is catastrophic to tissue quality, even after a year of therapy. Collagen quality is impaired. Incidentally, most of our patients aren't super active, super young, so we've got other things happening that also affect collagen quality negatively. And so we're going to need to be very, very careful with all of our techniques, but in particular some of these stretch techniques that target collagen. So, other precautions, gradually progress, right? You can always do more next visit. You don't need to overdo it today. Avoid stretching swollen tissue. Avoid overstretching weak muscles. And a lot of this is, I think, self-evident. But as a general rule, less is more, right? We don't need to overdo it. If you're not certain how far to push, do less. You can always add next treatment. Lots more on collagen to come. That's a collagen molecule. It's usually described as either wavy or crimpy. But a collagen molecule looks like that. If we added tensile force, we just straighten out the collagen. If we remove the tensile force, it returns to being wavy or crimpy. It's a very crude depiction, but big picture, that's what's happening. So collagen is the most abundant protein in the body, and it's the building blocks for a lot of the structures of the musculoskeletal system that we deal with, particularly the ligaments, the tendons, and the muscles. Collagen is responsible for the strength and stiffness of the tissue and is the structure that resists deformation, specifically tensile deformation. When you add a stretch force, it's the collagen that allows for and then resists further deformation. It absorbs the tensile stress. So, this is collagen. It's very crimpy. It's going to allow for that tensile stress to occur, but it absorbs it and it's going to resist further deformation. If we remove the force, it goes back. That's collagen. And again, we talked about the right side of this already. Immobilizing collagen profoundly weakens it, even in the absence of injury. This is the picture on the tile from this course, the stress strain curve. So I want to orient you to the picture, and then we'll talk about what it means. On the x-axis, as we read left to right, this is the percent that the tissue elongates, right? The percent deformation. On the y-axis, this is the stress or the load or the tensile force, probably the easiest way to think about that. That's applied. So down here, very low tensile force, and up here, really high tensile force.
Is the x-axis relative to the what tissue is it?
Yeah, so there are stress strain curves for, I don't want to say all, most biological tissues, but also most like non-biological tissues. There's a stress strain curve for metal. It looks different. But how much force, how much tensile force can a structure, in this case collagen, withstand before failure? So like if you're building a bridge, you want to know how much tensile force the structures can withstand before the bridge collapses. This is our bridge, collagen. Okay. So as we add a stretch force, a tensile stretch force or stress to the structure, it deforms. Okay? And then we'll go through each section. So if we add just a really, really small amount of force. So this is zero force. And this is like super low, just a little bit of force. We're working in this section that's called the toe region. This is where most activities of daily living occur, where collagen fibers, they go like that, we add some force, and they straighten out. And then we remove the force, and they go like that. Most of our everyday activities don't impart big stresses, big tensile loads on the tissues. And so everything is withstood by collagen. The collagen elongates as it resists further deformation, and then when the stress is removed, the collagen goes back. Your biceps tendon, as we straighten the elbow, the collagen elongates, and then as you go back to your resting position, the collagen shortens back up, becomes wavy again. If we ask our patient to move in the toe region, we're not going to create any semi-permanent changes in tissue length. All we're doing is straightening collagen, and then it goes back. Once we pass the toe region, we move into what's called the elastic range. As you see in the elastic range, the load or the tensile force that we give increases pretty significantly. We give that much more stress. On the y-axis, we went that much higher. So as we move into the elastic range, you're giving a bit of a stretch force to your patient. You're like, yeah, I kind of feel a stretch. And as we look at the deformation, we've moved pretty far now on that x-axis. Now we've taken the collagen and we haven't just unwind it, but we've applied a bit of a stretch force. We've taken a rubber band and we've given it a little bit of a stretch. But here's the key to the elastic range. Once we remove the stretch force, the tissue goes right back to its resting length. In other words, if we stress or add tensile force or load or stretch our patient, even to the very end of the elastic range, when we're done, all of the tissues go back to their starting position. If you're building a bridge, you never want to stress it past the elastic range. Is that okay so far? Okay. And I should have prefaced this slide by saying this is the biomechanical model of why stretching works. There's this point called the elastic limit, however, beyond which any further force given, any further movement vertically, is going to result in semi-permanent changes, semi-permanent tissue deformation. In other words, we created a longer structure than existed before. We've stretched the tissue far enough that now when I release this stretch force, the tissue doesn't go back down to its original resting length. Rather, it has a new, longer resting length. If we stretch past the elastic limit into the plastic range, we can theoretically create semi-permanent increases in tissue length. Now, if you read your text, it uses the term permanent, and I keep coming back to semi-permanent. If you overstress a bridge and the steel deforms or the concrete breaks, that's a permanent change, right? The bridge collapses. In our body, biological tissues do adapt. So if you were to immobilize, for example, a structure that you stretch to this far, it would eventually go back to its original resting length. So I say semi-permanent. Your patient needs to use these new gains in range of motion for them to become permanent. All right, so we stretch our patient just a little bit in the toe range. They don't really feel anything. Collagen straightens and then rewaves. We stretch our patient in the elastic range. They're like, oh, that feels nice. But when you're done, the tissues all go to their original resting length. No change on the goniometer from start to finish. If we stretch past the elastic limit into the plastic range, now we see that after we release the stretch force, this X has a longer resting length. We've created a semi-permanent change in tissue length. But watch what happens here. If we just add, again, the vertical axis, the y-axis is the amount of stretch force. If we just add a little bit of stretch force from X to Y, we stretch a little bit further into the plastic range. Now look, that tissue increases in length by quite a bit more than it was before. So, we want to stretch. This is the Goldilocks curve, like so many other curves. Not too little, not too much, right? We want to stretch into the plastic range. But if you could specify, you'd want to stretch into the early plastic range to allow for semi-permanent changes to occur, but not crazy excessive changes to occur. Now, here's what happens if we keep going too far. After we hit a point in the plastic range, we see that the collagen quality, its ability to withstand deformation, rapidly declines. And we hit this necking point where its ability to withstand tension rapidly diminishes until here. And this is bad news, right? If you stretch something too far, it's going to rupture. And the point of tissue failure is one that we should not be taking tissues to. So, big picture, theoretical model for the biomechanical reason that stretching improves soft tissue mobility. ADLs occur in the toe region. It might feel good in the elastic range, but stretching won't yield permanent tissue deformation. If we want semi-permanent changes in tissue length, we need to stretch into the plastic range, most specifically the early plastic range. All right, what didn't I say? Elastic, we have a proportional strain, change in stress and strain. This is kind of linear, right? Proportional change. As we add stress, we add strain. Elastic limit, tissue doesn't return to its original shape and size. Plastic range, we see that individual bonds fail, resulting in a semi-permanent deformation. Necking, the tissue gets much weaker, and then failure is bad news. Yes, sir?
When you say semi-permanent, how long does it take does it come back? Or?
Yeah, so semi-permanent. Your patient, like if we stretch something, we mobilize something, we get good gains in mobility, it's not quite time to pat yourself on the back. What we then need to do, well, let me ask, what should we do? Let's say you crush your joint mobilization. Like, we're gonna do some inferior gliding, some anterior, some posterior, you get that joint mobilized. You're like, okay, now we're gonna stretch your latissimus dorsi, we're gonna stretch your teres major, we're gonna really get those muscles loose. You're like, I am awesome at therapy. What do we need to ask our patient to do to help increase the likelihood these changes stick? What should we do? Yeah, have them I'm going to interpret that broadly. Have them use that newly acquired range of motion and then strengthen it. Because otherwise, if they just go back to their sling, all of those changes you made are reversible. So semi-permanent implies that that range of motion needs to be used. How quick will it take to return? Yes, ma'am. Oh, hang on, sorry. Joe got interrupted earlier.
A good example of the collagen going towards that necking would be somebody that went through like a drastic weight loss.
I don't know. Can you elaborate?
Like the amount of stretch skin that they have that can't go back to what it used to be.
Out of my wheelhouse, I would think that the weight gain is what's stressing the collagen, because that's adding tensile force. So then after a weight loss, you've had a permanent change in the collagen length of the skin, and probably in the number of fibers there as well, like in the number of skin cells. So I see where you're going. I'm not sure it aligns perfectly, but I think conceptually it works.
Just seeing like what a visual representation.
Yeah. Yeah, like the extensibility, we took it really far, and then it doesn't go back to what it looked like. Yeah, I think that at least conceptually works. There was one more hand. Hannah, go ahead.
It doesn't really sound good. Like necking doesn't sound good. Failure doesn't sound good. Maybe the plastic range. So is there ever any like situation where people would want that to happen? Or like what?
No.
Right.
No, I mean, well, surgically it may be indicated sometimes, right? Like if we need to restore motion to a frozen shoulder, like this would be the manipulation under anesthesia that we talked about last week. Let me connect this though. And the next slide, last slide we'll do before we break. The next slide connects it to tissue injury. And some years I share it and some years I don't, because sometimes it adds clarity and sometimes it adds confusion. So the stress strain curve, insofar as we've discussed it, is the theoretical foundation for how far we should stretch. How far should you stretch your patients? Not too little, not too much, just right? Goldilocks curve. If you're unsure of whether you should keep going or not, you're somewhere in here, just stop, do more next time. And this would all result in presumably a desirable increase in collagen length. Because why are we stretching? Because of reduced range of motion due to adhesions, contractures, or scar tissues. We're stretching to improve flexibility and range of motion when it's limited. So far the stress strain curve, we're assuming range of motion is limited. We're trying to mechanically deform collagen to make range of motion better. But sometimes we mechanically deform collagen when we don't want to. And this is another application of the stress strain curve. So we're going to talk about ligament injuries. And this is not a slide you need to memorize, so as you're preparing for the quiz next week, you can exclude this, or as you put it in chat, you can pull this one out. We'll cover it next semester. These are the grades of ligament injury. Briefly, it's like 2 pages in your book, we can simplify it into 10 seconds. A grade 1, it's like a little boo-boo. It kind of hurts. Grade 2 is a medium boo-boo. It hurts and it's hypermobile because we've had meaningful rupture in the fibers. Grade 3 may or may not hurt, but it's super hypermobile because we've fully disrupted the tissues. So a normal ligament here, like just picture your ATFL, lateral ankle. Normal ligament, all the fibers are fully intact. This is good. We have an inversion and plantar flexion injury, and at a grade 1, rupture of some of the fibers because we went into the early plastic range and we see like some small changes here. We went far enough that we created semi-permanent tissue change. Now, what would we do about this? It'd probably be immobilized so that it would scar down and go back to its original resting length. So immobilization would be helpful. What if instead of going into the early part of the plastic range, we went into the later part of the plastic range? Now we get pretty significant changes in the tissue. Again, not desirable. We don't want to be tearing ligaments. That's not a goal of stretching. But this would be early plastic range. This would be late plastic range. But then if we hit the point of failure, right, the tissue isn't even connected anymore. So the stress strain curve, we frequently talk about it as an application of our stretch forces. But it also explains our 3 grades of injuries: early plastic range, late plastic range, failure. What do? Well, we immobilize and hope it scars down. We immobilize and hope it scars down. And this one's immobilization or a surgical candidate. Yes, sir.
So it could heal without surgery, the complete rupture?
They may try to have it heal without surgery. It depends on the stability.
Depending on like the blood flow or just?
Ligaments aren't as well vascularized as muscles, so they have a reduced capacity, but it's, if not unstable, one of the options is conservative approach. Incidentally, if they rebuild this ligament, they use frequently like the peroneus tertius or plantaris, or another one of those structures that some people but not everybody has. It's kind of neat, kind of like using the palmaris longus to reconstruct the elbow. All right, stress strain questions? Yes, ma'am.
What maintains the deformation of the fibers once you get stretching? I'm picturing
Yeah.
someone in a clinic and they're stretching the patient, which could be, I don't know, I understand it as like static stretching when you're getting to that sweet spot of deformation. And then we were talking about giving them exercises that maybe like remove the available range of motion. Will that maintain the deformation, or will they come back to therapy the next week and need to be back to square one and be stretched the same way? That's what.
Yeah. So I want to give a tangible example kind of as part of the answer to this. So let's say you spend the first 15 minutes with your patient just doing manual therapy. You have them warm up on the arm bike. You do some manual mobilization and stretching to increase scaption and overhead reaching. Immediately after that, like right away, all right, now we're going to go to the pulleys. And your instruction to the patient is not like, just go up and down. Instead, your instruction should be, affected arm on the right, try to reach up as high as you can with the right arm, as high as you're actively able. Use that range. When it stops, use the left to help finish the job. So we're going to do like active or active assist range of motion from the patient's control. Then they're going to go home, like 1 or 2 exercises. Your home exercise program should enhance what you've done in the clinic. Go home, get a cane, use one hand to help drive the other. We're going to work that new portion. And at least when we're talking about this model, if they do that, theoretically they'd come back in the same position. Now that's rare. You know, there's always a little bit of a regression toward the mean, which is why therapy is not one day, it's a series of weeks. But how much to quantify it, I can't do that.
But the dynamic activities do maintain the deformation. They don't have to stretch it.
They should not have to continue to stretch it, yeah. Now they need to do their exercises, it's the rationale behind it, but active use of the limb should be considered part of the stretching process, because otherwise, like you put your sling back on, everything's going back, you just wasted your time. Good, go take a break, see you back in 10.
Good.
Okay.
Yes, sir.
I was about to say.
For this slide, you don't need a nose.